Ah,
Now I can hear you.
I'm hanging up my phone. Okay, there you go. Are you there?
Yeah, yeah. Can you hear me okay?
Okay. Dr. Kane, your mic is muted. Yeah, I can hear you, Dr. Miyamoto. Dr. Kane, cannot hear you. Let me make sure. Okay. Dr. Miyamoto, I can hear you. Can you see my screen?
Yeah, I can see there's a picture of myself and Dr. Kane and
There's a welcome.
Yeah.
Okay. Oh, that's crazy that by attending this meeting, you can see.
Yeah. Say, Patrick, if you can hear me, if you're on a Mac, it said hit Command M and Shift, and that's what unmuted me. I don't know why that is, or if you're on a Mac or not, but. And in the upper or in the upper right corner, there's a little mic, but for whatever reason, I get there's like a weird thing that says my mic's disabled, even though that's not apparently true.
It's also making me check everybody in as they come on. So, hang on. There's a box that says I can't unmute. I guess that's Dr. Kane. Hang on a second. Hi, this is Garvey. Oh. Okay, well, you're in the meeting, so. Yeah, but we need to be able to hear you. So, did you do the command, I
think it was like Command M and Shift or something all simultaneously.
Okay, you're muted now. So do that again. And now speak into your computer. Yeah. So maybe if you go into your settings. Output. Input. Yeah. That's it. Hi, everybody. Thank you for joining us. I can. Not on the computer. No. He just hung up. And Dr. Kane, you just hung up. But I'm glad you can see my screen. All right, here we go. All right, are you there?
Yeah, so that means moving through the computer.
I know. So, all right. Here's what we can do. If we can't figure out the mic on your phone, you can mute the mic on your computer and talk through the phone, and I can hold your phone up to my.
Up to try that. I can listen and do that, and I'll tell you.
You just need to make sure. Yeah. You just need to make sure that your computer is turned down. Otherwise, we'll hear the echo. Well, I can hear me. That's the only problem. I can hear the echo.
Garvey, are you holding your phone up to your? I can tell you how it sounds if you want to try it.
Yeah, I'm holding my phone up to my laptop so you guys can hear it. So here's what I can do. Let me turn off my mic. Hang on a second. Okay, guys, when I mute my mic, can you hear Dr. Kane speak? Hang on, I'm going to mute my mic. Hey, Dr. Miyamoto, can you hear Dr. Kane when he's talking on his phone?
No, because I think if you mute your mic, I can't hear whatever in theory would be coming
Oh.
through your mic. What happens if you hold your phone up to your mic, Garvey?
Uh,
Really muted though. That was better.
you tell me, it's kind of difficult.
Yeah, Patrick, say something else.
I guess, well, hi everybody. Sorry we're having technical difficulties. We're going to try to work through this.
It's a little jarbled. And Patrick, are you using like Google Chrome? Or I don't know if you're using a browser.
Google Chrome. Yeah.
Okay, yeah, that's what I'm on. Although there I can kind of hear you a little bit better.
I open up Teams on my phone.
Yeah, do you have Teams on your phone? Okay, yeah, if you try and what you can do is hang up the phone, join the meeting on Teams on your phone, mute your computer and talk through your phone and talk through your phone. Okay. Okay, all right, thanks. Okay, everybody, thank you. I know we're having some technical difficulties, but we are going to figure it out. It's just a little matter of time, and we will figure it out. I want to just open up by saying thank you for joining us this evening for our Power Hour featuring retentionable anchor use for labral and rotator cuff repair, presented by Doctors Ryan Miyamoto and Patrick Kane. Dr. Dr. Miyamoto joins us from Town Center Orthopedics in Northern Virginia. He attended the University of Maryland School of Medicine and completed residency at New York University Hospital for Joint Diseases. He completed specialized training in orthopedic trauma surgery at the Shock Trauma Center right here in Baltimore, Maryland, and went on to complete a sports medicine fellowship at the prestigious Steadman Hawkins Clinic in Vail, Colorado. Dr. Kane represents our Eastern Shore area from Orthopedic Associates in Lewes, Delaware. Pardon me. He attended medical school at Thomas Jefferson University in Philly and completed his residency there with the Rothman Institute. Following his residency, he completed his sports medicine fellowship at no other than the Steadman Clinic and Steadman Philpott Research Institute in Vail, Colorado.
Nice.
Both are board certified and members of the American Academy of Orthopedic Surgeons, the American Orthopedic Society for Sports Medicine, and the Arthroscopy Association of North America. Please feel free, if you will, to raise your hand to ask questions. We will open your mic to enable your engagement. This is intended to be a very open format, so feel free to ask at any time throughout the presentations. Hopefully, Dr. Kane will be able to get on through his phone. As always, we hope to provide you with new insights and connections for future consideration and appreciate your dedication to the perpetual pursuit of education for improved patient care. With that, I'll go ahead and still admitting lots of people, so hang on one second. I will get Dr. Miyamoto's presentation up there. Where's that? Whoop. One sec, sorry. All these people coming in. Apologies. Gonna stop sharing and share a different screen. Apologies. All right, went backwards. There you go. Dr. Miyamoto, can you see my screen?
Yeah, I can see it.
Awesome. Let's get that out of the way for you. And I will go ahead and click you through. So you just tell me when you're ready.
Okay, perfect. Well, again, thanks for having me out. I want to thank Garvey, obviously, with all our technical challenges, even though we did do a practice run yesterday, believe it or not, you wouldn't believe that seeing what's going on now. But that being said, thank Garvey, thank obviously Supreme for their support and my invitation out here to talk, and then certainly even locally the teams that take care of me both in Maryland and then TJ's team. I think it's called Supernovas, the Northern Virginia guys and girls, who are one of the more aggressive group of salespeople I've worked with, but they are fantastic nonetheless. So you can go to the next screen for me. So again, just a brief bit. I think I'm going to tackle more so on labrum and instability work, and then I believe Dr. Kane, once he's able to jump on, is going to speak more in terms of kind of rotator cuff and how kind of the anchors and technology can be used for that. But in terms of instability, just kind of the basics, and we'll kind of keep this brief. So there's kind of four, general categories of instability, at least in terms of directional. And what I found is that a lot of the newer anchors and guides, and we'll talk about which one I prefer and why. I think there's a lot of overlap, but specifically, I think if there's two types that I really think that the anchor makes a huge difference, it's for both that posterior instability, which used to be one of my least favorite cases. Posterior labral tears, posterior instability is now becoming actually one of my more favorite cases to do. And I truly think a lot of that is the ease of the implants that have changed so much, as well as multi-directional instability, mostly for the same reason. I think in the front of the shoulder, in terms of establishing portals and mobilizing tissue, I think there's a lot more room, or maybe just because we're typically as surgeons used to viewing from the posterior portal anteriorly. It's just a much more comfortable view, I think, for most of us, whether you're purely a sports med doc or not. But I think working in the back for a while was always a bit more tough. There's just less room. It's a weird look. The tissue, there's not nearly as much capsular tissue. The cuff is right on top of you. So again, those two things, posterior instability and I think multi-directional, are the two kind of directional ones where I really find it's a huge improvement from where we were even a few years ago. Next slide for me. So in terms of labral repair options, obviously there's a number of them, from knotless to knotted, and a lot of at least the recent literature in arthroscopy and AJSM and a lot of our sports meetings are about knotless versus knotted. And I think if you look at most of the data out there, again, not to make this too academic, certainly biomechanically in terms of pull-out strength, in terms of restoring labral height, in terms of maximizing capsular shift, in terms of ultimate load to failure, et cetera. There really is not a huge difference between knotted and knotless. I think some of the obvious discrepancies include things like, for knotted, for instance, is knot security, knot migration, things where before, even personally, I never thought it was a huge issue. I always, for a long time, preferred tying knots. I thought that was just more secure. I felt more comfortable. Although I will certainly say I'm not one to make change easily, but I've certainly switched essentially almost to purely knotless, whether that's, a slap repair, sure, but certainly for bank cart and particularly posterior labrum and multi-directional. So in terms of looking at kind of our menu of options, my anchor of choice at this point, at least for primary non-revision, kind of quote straightforward repair, is the 1.8 knotless fiber tack. Obviously their size going up from 2.4, 2.9, 3.5 in terms of push locks. I don't use a ton of those anymore. I think some of Arthrex's even internal biomechanical data may suggest that the fiber tack has probably a better pullout strength. 3.0 knotless suture tack, that one I had used, I think when that first came out, I had converted to that and was very happy for a while. although I have found the knotless fiber tack, and particularly the second iteration, the sutures seem to slide much easier, much more consistently. It's less kind of, on our end of things, holding our breath as we slide the action stitch through the middle of the anchor. And then up to a 3/5 swivel lock. These I've used a number of times, mostly for, I had 1 or 2 SCRs where the glenoid, it wasn't great bone stock, and the 3/5 swivel lock, I think, bailed me out in terms of almost like a revision anchor where the 1/8 had unfortunately not had excellent purchase. And then in terms of the knotted anchors, again, fiber tack, same, I believe it's same size, 1/8 if you want to tie knots. 2.0, 2.4, and 3mm was my go-to suture, was my go-to anchor for a long time for bank cart repairs. Although again, I've for the most part switched over to the 1/8 knotless fiber tack. Next slide. In terms of at least, some of the data, again, apart from biomechanically, I think there's certainly data to show that tying knots, apart from knot security and discrepancy, even in the same surgeon, same case, in terms of how hard or how consistent you tie a knot, regardless of those things, there's been some data that certainly shows that there is some migration of the knot after it's tied, particularly with multiple cycling of the shoulder. And so as hard as we can, whether it's a hip labrum, a shoulder labrum, to put the knot on the lateral side away from the face of the glenoid, it's been shown that over time with repetitive motion, there's certainly at least on some level, some knot migration that occurs, whether it's into the joint or not. And as a result, we often worry about, suture crepitus, which is purely just the noise that people make when they move their arm and complain about it. But more so, chondral abrasion, I think is a bigger deal when you start to carve out maybe a small area of cartilage. There you're starting to talk about more than just a nuisance. So I think, amongst other reasons, apart from the biomechanical data that shows, equivalent, if not better, pull-out strength, ultimate load to failure, et cetera, I think knot migration is a real thing. And that's been shown, I think, multiple times, including this study that was cited here. Next slide. So again, just in terms of knotless ones, again, my go-to is the 1/8 knotless fiber tack. I think one of the benefits, or at least one of the things that they did, whether it's the second generation or the third generation, I think the suture is now bonded slightly differently. So it does seem to slide a bit better through the anchor. At least I would say over the last 6 to 8 months, I've noticed an appreciable difference, as well as on the inserter. There's a smaller little collard piece that really helps to, I think, seat the anchor a little bit better, a little more easily before you start to mallet it in. Those seem like very small adjustments. I think it's made a huge difference in how frequently we have to burn an anchor. It's almost rare, knock on wood, anymore that I've seen that these don't slide through as they're supposed to. Whereas I think when the first iteration, particularly the knotless suture tack came out, I was a little more concerned every time we sank an anchor. Now I would say these kind of what I thought was a very minor improvement has made a massive difference, and at least in terms of surgeon anxiety through the case. Next slide. Garvey knows what I'm talking about. So in terms of the 1/8 knotless fiber tack, again, it comes in straight and curved guide options. We talked about it's the smallest anchor, at least for consistently used for shoulder anyway. I would say anecdotally, I'm more of a fan of the straight guide. I think part of that has to do with the drill guide for the curved anchor is still, I think, essentially a solid, almost like a pin. So while it does drill a hole, it doesn't really remove any bone. And not that we want to remove massive amounts of bone, but for me in the shoulder and certainly in the hip, I've had a little bit more of a struggle to get the anchor seated. I know, talking to TJ earlier today, there may be coming out hopefully soon with a flexible drill. I know that's still in the works, but in terms of my preference, I actually prefer the straight option. And as we go into the next few slides, when we talk about percutaneous insertion, I think particularly in the shoulder, that there's not a massive difference. Potentially for a multi-directional when you're trying to get real low, I think a curve guide is certainly something that's desirable. Although again, with a percutaneous 1.8 footprint, I think even if you're doing, say, a trans subscap portal to seat your anchor, I mean, you're really leaving a very small hole. Same thing with a posterior capsule, posterior cuff when we're working in the posterior part of the shoulder, and you're really trying to minimize any defect in the capsule or rotator cuff. I think because it's such a small drill bit, such a small anchor, you're really not burning, many bridges, even if you're coming trans cuff for anchor placement. The basic anatomy of the anchor itself, again, there's kind of a cordless fiber wire suture with a little purple mark that kind of helps us identify the fold over point, and then the shuttle stitch, which is technically a suture tape and a suture, so it looks different arthroscopically, although sometimes I think it's a little difficult to tell based on the angle of your scope. Next slide. Here's a video on the left. In terms of percutaneous insertion, again, I think it's almost say like a hip arthroscopy, or what's called a Seldinger technique, where we kind of enter with a needle, place a guide wire. Over that goes a small switch stick, as you'll see here. So the portal is expanded, switch stick goes down. And then on top of that, there's actually a cannula that goes down, followed by the drill guide. And so it does, for what it's worth, help to keep your place within your small little poke hole incision, which again is very small with these anchors. This one, I think, Garvey, we discussed, is for a 3/0 suture tack, I believe. I think there is one. Sorry, go ahead, Garvey.
Yeah, that's for it's not for the fiber tack, but it's the same approach. It's the same dilation method.
Yep. And so, and I think that's useful. Obviously, with a curved guide, that does not work. But for a straight guide, particularly again with percutaneous insertion, I think it's something, it just makes it easier. And again, anyone who does, say, hip arthroscopy on top, you're used to that anytime you set up your first couple portals. So it's a very natural kind of set of steps to place your anchor. Next slide for me. And then in terms of kind of, here's a brief, just a cadaver demonstration of kind of the basics of, and then we'll go through an actual case.
Just go on. There.
So in this one's in the beach chair position. I do most of my lateral, but nonetheless, this is actually going through a portal, which is even easier. And again, I think steps we're all familiar with as surgeons. You know, the anchor's placed, a lasso's passed through. In this video, they're grabbing both kind of the action stitch, which has been placed outside, you know, passed through the labrum itself, and the loop suture. This is a good example. In fact, you can do a single portal slap in this way if you want to, but that action stitch goes through the loop, and then pulling up on the non-loop side is essentially transferring the action stitch outside the cannula. That can be tensioned. And I think one minor point, which they show here, is using the kingfisher to actually grab a bit more tissue, pulling in this case superiorly before seating down the anchor. There's a couple reasons why I think that's important. Number one, in terms of grabbing more tissue and creating a more aggressive shift, I think that's certainly relevant. And then number two, I think the actual torque on the anchor, by grabbing the tissue, bringing it, in that case, anteriorly and superiorly before you're kind of really hunkering down on that action stitch, I think does take, for what it's worth, at least some tension off of the suture when you're going to seat the anchor. And we'll see that again kind of once we get to the case here. But I think that's a small, subtle point that shouldn't be missed. Yep, see if you can show that one more time. Kind of at the very end, there's a kingfisher that drops in. We'll see the labrum tissue being grabbed, pulled superiorly and posteriorly, essentially creating what looks like an anterior superior shift. The other way to do that I actually do, and I think gives you an even greater amount of tissue, is before I pass my lasso, particularly on the front side of the shoulder, so for anterior instability, say Bankart or anterior capsulorrhaphy, grabbing the tissue before you seat your lasso with a kingfisher, I think you can really get a monster bite and a massive shift. But nonetheless, I do think taking some tension off that anchor as you really kind of, again, hunker down on that tissue, it feels less scary, for lack of a better term, that you're going to pull the anchor out, even though we know it's strong, we know it's got great pull-out strength. So again, not a minor point. That's not hard to do, but if you don't think about it, you forget about it. I do think it makes a difference. You can go to the next slide for me. And so I just wanted to show a case. This was actually a 26-year-old, believe it or not, ortho sales rep, non-Arthrex, who had presented with chronic right shoulder pain. 26, works out fairly frequently. Had noticed some kind of persistent pain, a little bit of instability symptoms for a long time. Had gone through therapy. We injected her shoulder 2 or 3 times. She's a little bit of a hypermobility, so not a true, like, say, EDS, but does have some signs of kind of hypermobility tissue, kind of not uncommon, say, in a 26-year-old, particularly with a previous history of being a swimmer. That seems to be a very common phenotype that we see. In terms of our MRI scan, it showed obviously a posterior labral tear as well as a paralabral cyst, and then naturally she had a bit of glenoid retroversion. You can go to the next slide for me, Garvey. And so in her case, we had a lengthy discussion. I mean, certainly within the realm of possibility was discussing a posterior bone block, say like a distal tibia. She had never had any prior arthroscopic procedure. So looking at her scans, there's kind of a posterior labral tear there. She's got a small paralabral cyst. In fact, her glenoid, if you look closely at the glenoid, it almost looks like her articular surface, at least in those cuts, is almost concave as opposed to, I'm sorry, convex as opposed to concave. So again, we kind of talked about, you know, the history of potential re-tear, et cetera, versus going in, which is a much larger procedure, putting on a distal tibia bone block on the backside of the shoulder. So anyway, we elected to proceed with an arthroscopic procedure as her index procedure and see how she does. You can go to the next slide for me, please. So kind of, and hopefully this will show up. So she really had, we call it a load and shift or a posterior drawer. She had a very audible, palpable visual clunk. So as soon as she was asleep, the scapula stabilized by the stretcher. Can you roll that one more time, Garvey? I know it's a little kind of jumps a bit over Zoom meetings, but that being said, she truly had, you could frankly dislocate her shoulder. You know, we bring her out to the side and there was a gross reduction. Almost one of those that's like a nauseating reduction as you do it. So of course we do it 3 or 4 times, prove that we're there for the right reason. Arthroscopically, you can go to the next slide for me. So as we go and we kind of create our standard portals here. And so I create our posterior portal. We're actually looking posterior here. So after creating our anterior superior, anterior inferior portal in the intervals, I still like to create 2 portals on a rotator interval. Again, it's kind of a natural portal placement for most sports and non-sport shoulder guys. So here we're looking from the anterior inferior portal looking posteriorly, and not unlike say an anterior inferior Bankart or any anterior labral work, a slap tear, etc. First thing we do is, you know, mobilize the tissue, roughen up the rim of the glenoid. And as we do that, the idea is that we want to make sure, A, that there's enough tissue, particularly someone who's got chronic retroversion. Sometimes you worry they're not going to have the most robust posterior tissue or posterior capsule. Fortunately, in her case, I thought it was still a very reasonable tissue, as consistent with what the MRI showed. Can you spin that one more time for me, or rerun that one more time? So the other thing I was a little concerned about, at least from this angle, again, this is a posterior inferior portal looking backwards, was I was a little worried about the shape of her glenoid. So a lot of times when we talk about, you know, a pear-shaped glenoid or there being some kind of bony malformation, I was a little concerned. Again, I knew she would have some retroversion, but in terms of the actual shape of the glenoid. So again, as we mobilize, roughen up the rim of the glenoid, assess the tissue, I was a little concerned. You can go to the next slide for me, Garvey.
Lost my pointer. There you go.
Sorry, one more
Is that
time.
the same one?
Yeah, I think it repeated again.
Okay.
So as we're coming in here, I had actually switched to the anterior superior portal, and just kind of a little tip. I like to take my camera and actually slide it behind the bicep. So, you know, on the posterior side of the bicep is my camera, as well as where we're drilling from. I think it keeps out of harm's way the camera and your assistant who's retrieving sutures, and it just kind of gives you a natural block. So your cannula doesn't really come out. You have a nice, clear, unobstructed view. And here I was a little happier with the shape of the glenoid. So as we go in, we're drilling percutaneous, where the anchor seats, we get a kind of a slow but steady pulse, slow but kind of steady, gentle tug. And again, much like an anterior tear, my assistant retrieves the action stitch. I will tell you, I do think it's worth, I always kind of jockey those shuttle sutures. I think both from the point of, you know, if you're drilling into hard bone, right? Most of these instability patients, they're younger, their bone is very dense. Again, part of the reason why I like to use a straight drill guide as opposed to a curve guide, just my personal preference. But I do think, for what it's worth, just the anchors package very tightly. I don't know if maybe there's a little static between the sutures because they're packaged so tightly, but I do typically like to jockey that shuttle stitch even before we start working and pass the lasso and the action stitch, etc. So that's our first anchor. I think fairly low, at least to where I thought the labral tear extended to. Go ahead, you can, let's go to the next one. In terms of the repair, so again, we're coming in here. Sorry, jumped a little bit. Our suture has been passed. I like to use the 25-degree lasso. That's kind of my lasso of choice. It's small enough to get through a 7mm cannula, which I think there's a benefit to, particularly in the posterior side of the shoulder where there's less capsular tissue to work with. you want to try to obviously make a smaller hole in the cuff. So I found that works well. This portal, I think, is critical though. So with a single portal posteriorly, this is one where, as you originally create that when you put your scope in the joint, but if for whatever reason, when I look at that, if that looks to be either too high or too low, again, not for anchor placement, but more so for grabbing with a lasso. With our anchor, we're coming in percutaneously, so it's not a big deal if our portal's too low. But with a lasso, that's really where you have to make sure that whatever angle you come in at, you can grab a pretty aggressive bite of tissue. And so that's the one I will take my time. If I have to drop another switch stick in and place the cannula, I will. Can you go back again, Garvey? I just want to touch on one thing. So
Back on this particular video?
Back a little bit, yeah, just in that video. So yeah, so again, low, we can make a big aggressive grab with the lasso. Here we're grabbing our loop stitch outside the body. Again, there's a little marking on the action stitch. It's folded halfway through. And again, I think that these newer anchors, their second or third generation, they move much more smoothly. And you can see here, you can tension almost as hard as you want, certainly enough to almost lift the body off of the beanbag. You can see even our first anchor, we have a pretty aggressive bite, a nice kind of anterior superior shift. Again, we're looking inferiorly here. Second anchor, very similar. Again, you'll see us pass the lasso. And in this one, once we get to, you'll see this one, we actually kind of drop that kingfisher in, grab the tissue, pull it up, and you'll see, I think, an even more aggressive shift in terms of grabbing posterior capsular tissue and labrum in one big bite here. Again, a subtle point, the action stitch, it's part of it is flat wider, part of it's thinner. I think it's a little bit hard to tell, but in theory, it's there. Here you'll see us, again, we kind of essentially seat part of the knot, and here you'll see me come in with a kingfisher, try to grab a bit more tissue, cheat it up a bit, and then really kind of, you can go nuts on that action stitch to really secure the labrum. Yep, Patrick, I'll answer your question there in a sec. So here we're coming up there. No, that's a good, excellent question. There you see a nice kind of sling and pulling up proximally. I think we have a nice bite. And then here for the last one in the back, I actually came with the lasso in a different direction, but again, nonetheless, passed it through and yank it. There's a little bit of data, they had looked at, and one of the, I think, benefits is that you don't have to cut these sutures. So you can pass anchor 1, tension, pass anchor 2, tension that, then go back and retension anchor 1, pass anchor 3, tension that, retension anchor 1, 2, and 3. Mazaka did a recent study. It didn't show a massive difference. There was maybe some subtle improvements in terms of strength and kind of capsular shift. It wasn't clinically significant or statistically significant, but in theory, if you didn't like your first bite or you felt like you didn't have a good shift, you could potentially send a second anchor, seat that, and then go back, as long as you don't cut your first tail, kind of retension a bit further, which I think is a nice option to have. I think it's certainly even more important, say, in a hip labrum, but nonetheless in the shoulder, it's at least an option. Again, it hasn't been shown to make a huge difference clinically, but that option's there for you nonetheless. In terms of Dr. Kane's question, he asked, do we close that portal in the back? I think it's an excellent question. I did not in her, but certainly you could. In fact, I said to Garvey the other day, I should have showed a video closing that, almost like a rotator interval closure. I was, in this case specifically, I was fairly happy with our shift, but certainly I don't think there's a downside. And I think that is one of the benefits of having a smaller cannula there. A 7mm cannula, a 25mm lasso goes down. You're only putting a 7mm hole in that capsule and cuff. And therefore, if you want to close that, I don't think it's a big deal versus, dropping a second cannula in, making a second big hole. I think then I would have been a little more aggressive, maybe about sending a, capsular stitch or almost like I said, a rotator interval closure stitch. Next slide, please.
Repeat. There you go.
Yep. So there, I think, final look, and you can play that last video. So again, you can see where we started. It was kind of just that wispy tissue, wasn't a ton of, wasn't a real big bumper in the back. And then at the end, like I said, I think I was fairly happy. Again, we kind of got a nice aggressive shift both superiorly and anteriorly. So I think it's a much larger bumper. And we had talked about yesterday a little bit. Garvey had asked me, in terms of their footprint size, I think that's the other big deal, is we're able to get these massive shifts with just a 1.8 footprint, if you will, on the glenoid face. And I think the other thing that's a benefit, as opposed to, again, I was a 3.0 suture tech guy for a long time, is I think you could, whereas say you put in 3 suture techs, I think you could certainly squeeze in the 4th or squeeze in the 5th. if you really didn't like a shift that, or like an anchor that you got, or didn't get the bite that you wanted, I think there's much more room for adding an extra anchor, a fourth anchor, a fifth anchor, which I'm sure TJ and his team would love. But that being said, I think there's actually space for it with these smaller footprint anchors. And again, to me, the knotless is just as strong, and it certainly has been proven not just by Arthrex, but outside in a lot of our journals, or Arthroscopy AJSM, that they're just as strong. They do just as well as recreating labral height. Certainly, the pullout strength, I think, is as good or better than some of the previous biocomposite tacks and certainly the metal anchors, etc. You can go I think there's one more slide. Yeah. So again, just in summary. So yeah, knotless versus knotted. For me, knotless is really the way to go. And again, I was a big fan of a knotted horizontal mattress type anchor and configuration for certainly for my bang carts. And again, that's another thing I think Millett's group showed, is that mattress configuration versus simple configuration, there were very small, I think almost non-significant differences in labral height, tissue mobility, ability to create a shift between a simple suture mattress versus a horizontal mattress type configuration, which was truly a surprise for me. That was part of the reason why I like the knotted anchors. And again, you can actually do a horizontal mattress, not hard, with the knotless anchor as well, if that's a big deal for some of the docs out there. For me, yes, it's certainly less OR time, certainly less chance of suture abrasion, knot migration, things like this, suture crepitus, etc. I think with the smaller footprint, again, you do get the chance to put in much more numerous anchors, particularly say in that multi-directional where you're going, 270 degrees around the face. I think you're less worried about banging into another one of your anchors, and particularly with a fiber tax, that anchor is sitting up against the rim of the glenoid. So as you drill deep, you're less worried that you're going to disrupt one of your previous anchors. So again, that's now my go-to anchor with, again, I would say in an SCR, a 3.5 swivel lock as my backup. But yeah, I've been very happy with, and like I said, the second iteration of those anchors, I think, has made a huge difference in what I didn't think would be a big deal. So I've been very happy with those. Thank you. Hopefully that wasn't too long. I know it was a little over time there, Garvey.
Yeah, good. Thank you. Just a real quick question. Have you changed your post-op protocol at all since you started using the knotless version of the fiber tack?
Yep. Excellent question. Yeah, I would say that I'm probably, if nothing, a little more aggressive. I do think that in terms of more points of fixation, in my mind, makes a bigger deal. So I'd say my typical, like for the patient we just saw, so I usually have her in a sling for a total of about 3 weeks. Hers, I might go a hair longer only because of her history of hypermobility. But say you have like a big kind of collision sport, particularly say a male football player who has a tendency to get stiff, I would say they're in a sling max 3 weeks, and we get them out moving quickly. And again, I think a lot of that has to do with just, if you have more points of fixation, it's stronger. Again, a lot of that has to do with the smaller footprint. So I would say, yeah, certainly a bit more aggressive, except minus maybe if you really have like an EDS patient or someone who's diagnosed as hypermobile. Those are the ones I still maybe put the brakes on slightly. But yeah, if anything, it's certainly been faster. Brandon asked, are you aggressive with remplissage? I would say for a large anterior inferior Bankart repair, if there's a Hill-Sachs defect that I can visualize, I would say I am on the more aggressive side of that. There was a lot of talk about, is it engaging? Is it not engaging? What percentage? I would tell you, for me, it's a little bit less academic in that. I think when I first go in, my first look is to, say on an anterior inferior dislocator, is to see if there's at least a large enough Hill-Sachs that I can see fairly easily. If it's not hard for me to see when I first turn my scope, then yeah, I would say I'm much more aggressive about putting something to fill that defect. My usual order is I'll see that, I'll prep the anterior inferior glenoid, switch my camera to the anterior superior portal, look back, prep, and then place my anchors for my remplissage, pass my sutures for my remplissage, and then switch back to the back, finish up my Bankart, tie that off, and then tie off the remplissage. I think if you wait at the end, I found out the hard way, it's very, very difficult to see. And if you do it right at the beginning, I just worry, manipulating the shoulder, you can beat up your repair a little bit. But yeah, I would say if I can see it fairly easily, Brandon, then yeah, I typically will stick an anchor in. If it's a real large one, typically a couple anchors.
Awesome.
Thank you very much, Dr. Miyamoto.
Yeah, thank you
Hang
guys.
in
Thanks
there.
for having me.
Of course. Dr. Payne, can you unmute yourself? How's our video?
Hopefully okay. How's it coming across?
Yes, I love it. Can you see my screen?
Perfect. I can. Yes. Thank you.
That's awesome. And I'll just click through at your command.
Perfect.
Thank you so much.
Good. No,
Thanks,
thank you guys.
BK, for
Thanks
getting
the yeah, thanks for the technical difficulties. Thanks BK for the tip. Thanks Dr. Miyamoto. That was great. But yeah, I'm going to be dealing with the rotator cuff repair side and kind of more iteration of the same with the knotless technology, using this time more swivel locks and what to do with the extra, particularly the dog ears for a rotator cuff repair. So we can go to the next slide. And again, I will kind of get more to the surgical technique side of it, but just dealing overall with rotator cuff repairs, there's a lot of stuff that we can't control, but the stuff that we can control as surgeons is really the repair construct. Next slide. So, there's a lot of data that shows, and pretty much in all of orthopedics, I think if you try to restore the anatomy, that generally leads to restoration of function. So we're trying not to go for the single row repairs like you see up there. We're really trying to recreate that entire footprint. Next slide. And really going more for repairs that look a little bit more like this. So next slide. Again, not to get into the huge debate double row versus single row, but there's a lot of data out there that double row and transosseous equivalent double row really helps to restore the footprint of that rotator cuff repair and really helps to provide better compression, which does, I think, overall lead to better clinical outcomes. But next slide. You can see the biomechanics. It leads to less gap formation. And again, improve footprint coverage, and it also helps to add some resistance to shear in these repairs as well. Next slide. So I have to, give Dr. Millick credit, who trained me out in Colorado. This was published in AJSM, and this is just one. Again, there's a ton of studies, but one double row repair that looked more at the clinical outcomes, and you can see the kind of patient characteristics there. But all of them were transosseous equivalent double row repairs. Next slide. And he really showed that it was a greater than 95% survivorship for these patients with patient-reported outcomes at 10 years. Next slide. So you can really see he kind of was one of the pioneers, I think, and helped create the speed bridge technique. And I think a lot of the people, hopefully, on this talk tonight are really familiar with it. But we're going to kind of take it to the next level. So the first speed bridge, more just the traditional swivel lock anchors, but we're going to show a little bit of the new kind of things out there with the knotless technology and also the fiber tacks as well. The next slide. Again, just real briefly, the kind of clinical benefits of the speed bridge repair. It's the transosseous equivalent. It really maximizes that contact between tendon and bone. And I think, all of us as sports surgeons, whether it's the shoulder or in the knee with the meniscus repair, the enemy to healing a lot of times is that synovial fluid. So it really protects that healing zone when you increase that compression, particularly at that medial edge. And I think it does help, again, to lead to better outcomes and better repairs. And then the speed bridge part of it too, with the fiber tape, better compression and that swedge on that fiber tape really helps with minimizing the steps required to pass that suture and just leads to overall efficiency in the OR. Next slide. So I won't belabor this point. Dr. Miyamoto had a really nice with all the different anchors out there for labor work and kind of the same available options for, cuff repair as well. But we're really kind of focusing more on the swivel lock anchor on this one. Next slide. The speed bridge, again, hopefully a lot of you are familiar with it, but it comes in one convenient package. And this, again, was the traditional one with the, not the knotless version, but with the 4 biocomposite swivel lock anchors with tape. But next slide. If you look, again, this is not to belabor the point, but I think a lot of you guys know the speed bridge technique. It's a really good video that I think you can see on the Arthrex website. So I'll probably actually, Garvey, have you click through that one.
Yeah, I'll get past that.
And it's really more this. I think trying to show you the updated version with the knotless swivel lock technology now. As you can see on the left, the medial row has a swivel lock anchor with the knotless technology. So you can actually create either ripstop configurations to throw your tape behind that, or you can connect the 2 medial row anchors, as you can see in the right side, and create almost like a double pulley system, again, to try to force out almost like a pasta repair to try to not have that synovial fluid creep in at that medial margin and really increase that footprint compression. And then at the bottom part of that screen, you can see with those lateral row anchors, the kind of how you can add that dog ear compression. So if you finish your repair, you can go in and kind of, again, deal with the extra and really reduce that dog ear well back down to the greater tuberosity. Next slide. So again, here's just a zoomed in version of what that looks like. And it's almost, the same idea as the fiber tacks that we saw previously, but this, again, is feeding into a swivel lock anchor. And again, you can do it singly or you can do it doubly and connect the two to create that kind of double pulley repair. But it is, again, the fully threaded vented anchor design from the swivel locks that really, I took it out, but that one picture with the swivel lock with the canine model that really shows that bone ingrowth is amazing. I think it really incorporates. So next slide, you can see kind of this video I think is helpful. You can see first there, right there, is that kind of interconnection between the medial rail anchors to really create that double pulley system. And this really is showing how you can reduce that dog ear at the end. And you can do it under direct visualization and see that compression and how you can really reduce that tissue back down to that lateral rail anchor. Next slide. So and then again, I think the utility of these is you have so many different options available, whether it's the medial row, the two of them, or the lateral row. You can create, again, rip stops, double pulleys. You can use that to incorporate a graft to augment these repairs. And I think it just really affords you a lot of flexibility because, no real rotator cuff tears are the same. So it really depends what you want to use for your patient, what the tear looks like, what their bone quality looks like. And I think it just gives you that flexibility and options in it. Next slide. So this is kind of what looks like, again, that illustration up at the top, but again, intraoperatively or with arthroscopic pictures, what the kind of final repair construct with that dog ear reduction on the left and the double pulley repair on the right. You can see. Next slide. So this is kind of taking you through a cadaveric case that we just did. BK was gracious enough to help me with this case, but the left side there, you can see just doing the standard speed bridge repair. We've already put the medial rail anchors in and passed the fiber tapes and suture through the cuff. And again, bear with us. It's a cuff, not the best tissue, but I think you get the idea. And we tried to pass the tapes in a way that would create purposely a dog ear at the end to show you. But you can see on the right, we've passed through the medial row, and now we're bringing out to the more posterior lateral row swivel lock. Next slide. And then you can see on the left again, now we've done that one, and now we're putting it into the more anterior lateral swivel lock anchor. So a lot of times when you're done this, if it's a smaller repair, like, oh, that looks great, you're really, really happy. But then sometimes, if you can anticipate a dog ear, you may have put a fiber link in already and already incorporated it into that swivel lock. But what happens if you're done? Previously you just had that number 2 fiber wire suture in that swivel that you have to just, tie and use that to reduce the dog ear. But now, again, this knotless technology gives that flexibility that you don't have to tie. And it's something that, if you switch that camera, you're looking from the back, but if you switch it to that anterolateral portal and look down, you're like, oh man, there's a dog ear that I didn't appreciate. It just gives you that kind of bailout option at the end that you can really. So you can see on the right side there, we've kind of identified that anterior dog ear, and we're taking the scorpion and we're taking that fiber wire, or the repair stitch, I should say, through that tissue. Next slide. And then you can see we passed it through the tissue, through the dog ear, and now we're bringing it over to the anchor. And I'll show you on the video how I agree with Dr. Miyamoto. I think they really, and I know this is swivel lock, not fiber tacks, but I think they have changed the suture bonding, because in the past, especially with the fiber tacks, you had to pull the repair stitch all the way down to the anchor and then really like jerk on it like 6 times. And I did break a few anchors, or it just kind of the suture broke, I should say, when you were doing that. But now, to pass the repair stitch through, it's really simple. You just do steady, gentle pressure, and it really goes through much, much easier. Next slide. So this is kind of what we're going for at the end, where you can see this speed bridge repair with the 2 dog ear reductions, one in the back, one in the front. And then I'll show you how we did the double pulley and the medial row at the end. Next slide. On the left, just to point out again the kind of specifics with the anchor. I'm not sure who on the call is familiar with it or used it and hasn't used it, but the repair stitch is all the way on the left, and it's the blue stitch. And then it does have the loop tape and a flatter tape, so it's kind of hard to appreciate there, but I do think you can see it depending, like Dr. Miyamoto said, on the angle of the scope. Your assistant can either pull on the loop down to identify which one you're trying to pull out of the cannula, or that one's a little bit more rounded and the other one's a little bit flatter. I think you can appreciate that sometimes intraoperative. But if we go to the video, Garvey, if you play that. So again, just kind of more of the specifics on loading it. Just like Dr. Miyamoto was saying, same concept. You pull that repair suture through and really double it over to that purple line. That's just to make sure that you have enough of the repair suture being fed into the actual anchor. And then I think this part right here, a little glitchy, but you're gonna kind of have your assistant really make sure you also on this step that you're watching your assistant or you're doing it, that you're really keeping it looped over so you don't lose the suture and it doesn't come out of the loop. But now we're loading it in, and you can see right there, you're going to see the purple go through pretty soon, and it loaded through. And again, that was a lot easier than what it used to be, where you had to really jerk it. You had to, this, it goes through a lot easier. But you can see with direct visualization there, the reduction of that dog ear down to the greater tuberosity. You can see how much it's compressing that tissue down. One other kind of pearl that we're about to show here, to get a little bit extra compression and to save your hand so you don't cut yourself, you can roll it around a co-band. So similar to the tightrope in the ankle where you use those two blue sticks, this is just another way that, you know, it's just a little bit more controlled and you're not cutting your finger. And it's a nice kind of way that you just roll that co-band up and it really gets you a little bit more compression. And again, I think it just feels better. It doesn't, you don't have that like kind of nervousness pulling it. I think it's a little bit more controlled. And then, you know, just go in and cut it and pretty much done. The next slide there. We don't have to play that one. It's kind of more of the same. It's just showing the posterior dog ear reduction. It's kind of more of the same thing, to be honest with you. But if next slide, you can see kind of more showing you the kind of double pulley repair. So you just loop the two. Again, almost just like a pasta repair, where you load the repair from one anchor into the other, and it really does provide that medial row compression. And again, just trying to keep that synovial fluid out so that footprint's nice and compressed and heals well. Next slide. So that's kind of the basics with the swivel lock, but then kind of further, I do appreciate that again with Arthrex, they're never just satisfied. You're always looking for improvements. So the medial row fiber tack anchors or something else that's kind of coming out newer that you could use for the rotator cuff repairs, but also they come in both knotted or knotless and, you know, the traditional form as well. So if you play that video, they'll kind of run through that a little bit. And again, it's only 2.6, so it's pretty small footprint at that medial row, and you can put a little bit more of them in there. But again, they do come in the just regular and then also the knotless version as well. So again, it's just giving you a lot of flexibility, a lot of different ways you want to do the repair with, again, rip stops or medial pulleys. And you know, I think it's just giving you all those options that you want to do for whatever the tear needs at the time when you're in there at the time of the repair. But I think it's just highlighting again that knotless technology is just a lot of flexibility. So just kind of showing more of the fiber tack anchors. You could probably go to the next slide. And this kind of just shows a little bit more, but that's the final kind of sort of speed bridge-esque repair. And then here, yep, there's, again, kind of going over the fiber tape that's involved. And then, again, this one you could do with a guide or without. And you can, there are drills and punches, just like we were saying with the labrum, with the curve guide and straight guide for a hard bone. There's more drills and punches available if you need it. Next slide. And again, just showing you the difference, just zoomed up in the regular versus the knotless version. Again, next slide. And kind of the same video. So next slide, I think. Yeah, perfect. And then next one more. I think it'll show you more of the illustrative videos. Again, you can see on the left there that kind of how they're all linked together, and that kind of medial pulley repair again. And this one on the right doesn't show because it's not the knotless, but if you go to the next slide, the illustration and video show, again, that dog ear reduction. So now we're back to the swivel lock anchors with that knotless technology that you can kind of do, again, both options for that medial pulley with the fiber tacks, but then also the knotless for the swivel locks for the lateral row as well. Next slide. And then this video, if you could kind of skip all the way to the end there, to the end of the video, I'll kind of just zoom it up. Just again, I think repetition is helpful just to see. So again, like
I don't know how fast I can go. There you go.
That's okay. Yep, almost all the way to the end. He'll show you again this kind of really nice fiber tack tape repair, but and you think it looks great, but there's a dog ear at the end. So again, I think it just is helpful. You can not maybe try to stuff 3 tapes and a fiber link in one anchor. It's already loaded in, and you can use that knotless technology for that lateral row swivel lock and reduce that dog ear, and really not have to worry about pullout strength much. I think it really, those lateral row swivel locks are really solid. And I get sometimes worried like, oh, you're going to pull the whole anchor out, but with that co-band roll, and I just think it really, they did help with the packaging that I think the suture's smoother. Again, I agree. It doesn't really kind of make you nervous, pulling on that knotless repair at the end. I think it goes in there a lot smoother now with whatever they did. I'm not sure. Again, I'm not sure if it's suture or what, but it does go a lot smoother. And that's all right. If it won't go, it's kind of just, again, more of the same, showing that repair stitch going through that dog ear and pulling
Yeah,
it
I don't
down
think
to
it's
the
gonna let me
knotless.
advance the it's not gonna let me advance the PowerPoint.
Oh, okay.
It's
Well,
okay.
that I can't help. I don't know what to do with
That
that.
is a different issue. So I'll wait for it to respond. Um, I don't know if you're about to talk about this or not while we're waiting for this to wheel through or do whatever it's doing. Were you able to have you used the knotless swivel lock on the lateral row to tighten up maybe a loose piece of fiber tape from a medial row?
Yes, actually, so we kind of did that in the lab too, but we didn't get the video of it. So again, sometimes when you're doing those speed bridges, like, it looks good. The first one you put in looks great, and then when you go put the second lateral swivel lock in, it kind of makes that first one sometimes loosen up a little bit. And you're like, oh man, it looked really good, and now it just loosened up. Well, if you actually take that knotless piece from the lateral swivel lock and go underneath, if you have room to go underneath that tape, you can actually use that to almost take some slack out of the kind of loosened up fiber tape from the medial row as well. So yeah, we didn't get a video of that, but you're right, Garvey. That is something that you can use. I don't know, I can't quantify it. It might just be by like a few millimeters or something, but it does actually tighten it up and make that tape lay a little bit flatter.
I'm gonna get your PowerPoint back up. There it is. Sorry about that. Here,
And truthfully, I think we're all the way at the end anyway for
pretty
summary,
close.
so it worked out great. Yeah. Just
There
saying,
you
it's
go.
again, just I think the knotless technology just gives you a lot of flexibility. And I think it's a really useful tool for reducing the extra, whether it's the dog ear or the extra redundancy in the tape, or the medial pulley system as well.
Awesome. See what's going on over here. Does anybody have any questions for Dr. Kane? Actually, Dr. Miyamoto, it looks like you did. What's your go-to anchor for the SCR, Dr. Kane? Hello? Dr. Kane? You're muted again. There
Oh,
you
sorry, I
go.
missed that. I think it cut out for a minute there. What was that?
Sorry, what's your go-to anchor for the SCR?
Honestly, I'll be completely open. I really don't do those. Yeah, so I probably defer to Dr. Miyamoto. Luckily, I kind of stick to the straightforward sports cuff tears. If it's something bigger than that, I studied at Jeff at Rothman, and the balloon is looking interesting, but I really don't do SCRs. I have to be completely honest.
We'll have to turn you on to a
I
tuberplasty.
know, right? Yeah.
Dr. Miyamoto, what are your anchors for the SCR? What are your go-tos? You have to unmute yourself. Hold on. You turn it off? Okay. I've lost everyone. Attendee page. We lost you, Dr. Miyamoto. Okay. Let's see. Dr. Facio.
Oh yeah, no, I'm back, Garvey. Can you hear me now?
Okay, there you go.
Yeah, I was gonna say no. So yeah, I like the knotless fiber tacks on the glenoid just because I think they're independent, right? So if one pulls out, you can back up and I told you my backup on the glenoid's a 3.5 swivel lock. I think once or twice I've had to use for a little bit older patient, maybe glenoid bone stock's not as robust. Maybe my angle was off, but and then ladder, I still use swivel locks, almost like a speed bridge, but I was just wondering how many people have converted to kind of fiber text purely for the medial row for cuff. For me, it's very random. It seems to be like if TJ or Lauren covers me, they work, and I've had some trouble if Shannon or Sean covers me, having nothing to do with them. It just seems to be how it works out, unfortunately. I just didn't know what other
Rep
guys were doing.
related.
Exactly, totally rep related, 100% rep related.
Well, Dr. Fasihi said he uses knotless fiber tacks for the glenoid and swivel ox for the humeral side on his SDRs.
Okay, yeah.
We cared. We hear you, Dr. Fasihi. Does anybody else have any questions or comments for Drs. Kane or Miyamoto? All right. Well, thank you everybody for coming. Thank you, Dr. Fasihi, for the compliment. And you guys did a great job despite our technical difficulties. We got through it, and I thought it was great. Really appreciate you coming on board, and really appreciate everybody who got on to listen tonight.
Great. Thanks again for having me, Garvey. Appreciate it. Thanks, Supreme.
Yeah, thank you. Thanks for having us.
All right. Thanks, guys. Take care.
Have a good night.
Stay tuned for the next one.